please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
It's just having two awesome people on the same connection at the same time. We're just too awesome for the internet.
Too much bandwidth.
Speaking of too much bandwidth, I am almost done the last couple slides for my presentation I'm doing at the advanced. And
Thank you.
I was just gathering all the data because one of the cases that I'm talking about is something that I've been working on for almost a year, doing pictures before and after, pinwheel, gait assessment, pain, comprehensive case I've ever done. And I, in general, feel like it's a bit of a failure because I would have liked to have had more magic.
Yes.
But when I look and I see the improvements, and what hit me was the testimonial that she wrote, and what a difference in all the relief. And I thought, wow, that this was a success.
Oh, as long as it's a success to the patient, you're fine. And that's what's different is the lights. As long as it's a success to the patient, that's all it takes. And I think sometimes we come to expect maybe a little bit too much closer towards perfection.
Yeah.
But aiming that way, what is that? If you aim for the stars and hit the moon, you're still ahead.
Right.
That's where
it's very hard. Somebody was asking me yesterday, what is the toughest obstacle I have with the job that I do? And it is being a perfectionist.
Yes. And yeah, it takes a while to get over that. At some point today, we're going to talk about knees, no doubt, after what we did yesterday. But part of the challenge with repairing patients is we can't put tissue back that's not there. And for some reason, people seem to expect to have surgery on something.
Yeah.
And they don't expect, or they are disappointed with, angry about, surprised about the downstream effects.
Right.
So while I had a hysterectomy and then they took my ovaries out, and while they were there, they took my gallbladder out, and then I got a kidney infection in the hospital, and now I have low back pain and knee pain. And to the patient, those are separate things.
Right.
I have low back pain and knee pain, and I had all this stuff done to my abdomen. And we want to be able to, they want us to fix their knee. And we start working on the abdomen and the low back, knowing that the knee is down on the list. Those patients are the most difficult, I think, because their expectations are not realistic. My favorite patient is the case that I'm doing at the symposium. And he has lived with impossible pain, 300 plus surgeries on his face to rebuild it after a gunshot accident. And the high spot, the magic, was to be able to close his mouth so that he could drink from a cup without dribbling and actually could use a straw.
Right.
So, I like being a perfectionist. It aims us in the right direction.
Yeah.
As long as it doesn't make you crazy or too crazy, you'll get over it. After 30 years, you can't possibly fail as many times as I failed. So
yeah.
You get used to it.
And you've always framed it that they're all, when we say to our kids, FAIL is just an acronym for first attempt in learning.
True.
So
Or in my case, maybe the 300th attempt in learning, but that's another thing.
that is FSM, right? That is what we do is we come up with the best hypothesis that our training gives us as a starting point. And I think that is we talk about it probably every podcast. That is the uniqueness of what we do because of all the different professions that use FSM. So obviously a PT standing point is going to be different than a chiropractor, than a massage therapist, than a personal trainer. And even within the same framework, like my training, the osteopath, that was the Dr. Philip Greenman was the model that we based our assessments on. His model is completely different than a different osteopath. So we all come from different starting places.
And FSM is the tool that is useful almost no matter where your starting place is.
Yes.
As the key is, I have a pet peeve today. The key is using it as a tool based on understanding the process of it started here. These are the 15 or 10 factors you have to deal with at the beginning. This is how you think about it. And this is how you approach it. And you combine it with the other things that are done for that thing. Like the advance this year is 2 days. There's 423 slides. It's just not going to happen. So in the advanced, almost everything I'm going to get to is how you think about the clues that you get and what you do with FSM for it.
Yeah.
On Facebook, which I should never open before bedtime, there's a group in Friends of FSM Microcurrent. It's not the practitioner base. And somebody posted, I understand that FSM is dangerous when used to treat CCI, craniocervical instability in Ehlers-Danlos or in ligamentous injuries. And it's like typing back, no, where did this disinformation come from? As it turns out, the person who posted that is using a pre-programmed device made by somebody who used to be 13 years ago an FSM practitioner, core instructor sort of person. She made a device, but it's all pre-programmed. And this craniocervical instability patient had a Zoom call with the person who programmed this pre-programmed device. And then her neck got worse. Duh. You can't do that. It has to be combined with osteopathy, appropriate physical therapy, appropriate supportive measures to get you where you want to go safely.
And I think having a rudimentary baseline knowledge of, at the bare minimum, and this is what I have experienced in my short time teaching, is to.
It's been almost 10 years.
I
did the math yesterday when I
know.
was explaining after. If everybody wants to know, yesterday I had a knee patient. I'd seen her 4 times and it's good. And then it goes back to where it was. And that's okay. It is absolutely, I already worked on her trunk. I already worked on her abdomen because she had a tummy tuck and liposuction. Already did that. And I worked on the knee and it didn't, she's almost at square one. She's better, but square one. And I called you for the first time in the 12 years that we've been working together. And it's help. And then you start speaking what appeared to be English. Words were in actual English. But you switched to a different dialect, the dialect of osteopathy and PNF and muscle, energy, technique, all of which are foreign languages to me. And I had to tell the patient I've been working. It's been 12 years.
No.
2014
Yeah.
in San Francisco in the restaurant, and you said, this is what I want to do.
Yeah.
Has it really been 12 years?
It is incredible. And I was talking to somebody, we're in the same sort of circle, and he's tell me about what you do and what this is. And it's funny, I swear I know what FSM is, but I think of this giant blue metal box with dials and needle. I'm like, yeah, that was the first. He's like, wow. So he's like, I think in theory, I've been doing FSM longer than you. I'm like, no, because you haven't. But anyways, yeah, it feels like it's just been a minute, not 10, 12, however many years. But going back to teaching it, I hear your voice all the time about safety. And for me, what I've noticed is if we can start with a good exam and at least rule out pathology. And that was the baseline of a lot of the osteopathic assessments, was like the first set of tests was to rule out pathology, whether that was disc, SI joint sprain, ligature instability.
Lymphoma, colon cancer, ovarian cancer, aortic aneurysm, deep vein thrombosis. There are some serious things that
Right.
act like, let's say, back pain. And
Right.
I had a patient that presented with back pain and described passing a kidney stone. Well, in my clinic, I have urine dipsticks. And I said, oh, let's have you go pee in a cup. And he went, I just have back pain. I said, let's make sure. His back has been achy up around T11 for close to a year, and he doesn't see doctors.
Mhm.
And I had him pee in a cup. He's got white cells, not just blood from the kidney stone that I expected, but he's got white cells. And that's not okay.
Hmm.
And we looked and the dipstick's outdated. So we ordered some new dipsticks. He's coming in tomorrow. We're going to do another one. And what do I do if they're still there? Then you leave here and you go directly to urgent care. You have a kidney infection and you've probably had one for a year. So you
Wow.
could adjust his back, work on the tight muscles in his back forever. And without a dipstick, ain't going to get better.
You have everything at your clinic, don't you?
I think in worst case scenarios, it's
Right.
the reason the dipsticks are outdated was when I ordered the furniture for the clinic and the paper towels and the toilet paper, we ordered urine dipsticks
Hmm.
because you never know when the guy who comes in and wants you to work on his insulin resistance. And how do you assess that patient without you doing a urine dipstick and looking for ketones or
Right.
glucose? If his glucose is 200, it's you're not the answer.
Yeah.
You're not the only answer. Yes, I can work on insulin resistance, and you're going to see your doctor. Why? I don't have a GP. I don't. It's no, just no. This is why.
Yeah.
It's like rearranging the deck chairs on the Titanic.
Yeah.
Makes you feel better, but it doesn't change the outcome.
And people get really caught up in, and the core is full of all these different tests and scenarios and cases and things. And you don't have to be an ordering practitioner. I can't order x-rays or an MRI, but if something flags that's concerning me, it's a quick conversation to say, in order for me to confidently proceed with your treatment of care, I think it'd be really great if we had some more information. So why don't you go to your primary care and explain the situation and maybe ask for an x-ray or an MRI or whatever and leave it to them. It is an easy requisition for, because I have never not had somebody get something because and you don't want to scare anybody. I can't die, even though I know in my heart what is wrong. You can.
Yes, you can scare somebody. Sometimes it's your job to scare somebody or make them aware, acutely
Yes.
aware, maybe
Yeah.
without being scared.
Yes.
And I'd go one step further because people don't remember things they hear unless it's been said 7 times. But they usually will keep track of a piece of paper you hand them. So one of the things I have in my clinic is a notepad that's half of an 8.5 by 11. So it's this big and it's in duplicate. So it's got the clinic name and address and blah, blah, blah at the top. And then I put the patient's name and the address and the date that I wrote the note. And then it says, ask your MD to
Hmm.
order MRI, X-ray, ketoprofen and lidocaine. Ask your MD to consider switching from this medication that is making you demented and depressed to perhaps a different medication with a different side effect profile. Because I look up, you don't have to know about drugs because you have this. That's silly. Because you have this and you go to Safari or whatever, and you just put in side effects of whatever the patient's taking, or you put in that drug, and the side effects will come up. So yesterday, I have a patient that has been complaining of a deep ache in her bones and muscle pain, and it sounds like a 40 and 89 central pain thing,
Yeah.
but she has not had an event that would explain that.
Yeah.
And so tell me the drugs you're on. And she said, oh, yeah. So she gives me this list, and it's okay. Somebody with dementia does not belong on statins, so we're going to have that conversation. But this one, I'm not familiar with this. So I looked up. All I said, put in was the name of that drug. And on the list will be common and rare side effects. Common side effect, number 5 out of 7 common side effects was deep bone pain, and number 4 or 6 was muscle aches and stiffness. I can do whatever I want with FSM, but as long as she's on that drug, which she doesn't actually need. Do you know why you're on an immune suppressant? Do you have an autoimmune disease? No, I don't think so. Okay. So on her list was ask your MD why you are on X and would he consider reducing the dose or trying you without it, or so, and I put it on paper and I sign it, and it's a one of those carbonless carbon things. So the patient gets the original and the copy goes in the chart. So I have a record that isn't buried in my handwritten chart notes about what I suggested that, have we done that yet? Oh, I forgot. Maybe you should write it down again.
Right.
Sorry, I don't mean to just babble on.
It's not, because this is like piggybacking on what I wanted to talk about today. Is I have a slide in the sports course, or a section now. It's grown from one slide to a few of when it's not working. Because when you're that kind of roller coaster trajectory that we have, that learning curve of you take the course and then you're on the plane going back home and you're like, this is impossible. I'm never going to remember it. There's too many frequencies.
Sorry.
It's overwhelming. My brain hurts. And then you start implementing it. And I don't know about you, but I hear this quite often, that you start fixing everybody. It is slam dunk after slam dunk. The universe deals you a solid. You're like, this is the greatest thing ever. Everybody should be doing it. you're treating families and grandmas and cousins and police officers and teachers and their kids, and it mushrooms. And then it kind of stops, or you get at this standstill where the slam dunks aren't slam dunks anymore, and you start thinking like, what am I missing? But the great thing about that loop, that part of the roller coaster, is by then you have a Facebook family or an FSM tribe or people that you can call or text and basically describe what you've done and say, what have I missed? And then there's so many people from different professions that'll be like, try this. They might have that. Did you think of that medication? Maybe the knowledge just keeps growing. And then you've mentioned this time and time again. And then it's pattern recognition, because once you see something for the first time that led you down the wormhole of calling everybody that you know, you're more apt to see it the next time it shows up, and it will come back to your clinic again and say, remember me? Now you know how to treat me.
Well, and you find it sooner.
Yeah.
So the thing that annoyed me yesterday about that patient was, yes, I knew it wasn't her knee because I started out by working on her abdomen, because the knee didn't bother her till 4 weeks after her abdominal surgery. I started there, but I was mentally focused on the knee, and I felt like I didn't see everything soon enough. I did find an adhesion in the femoral plexus and the gemellis that I had missed before. But generally speaking, you find it sooner rather than later. And
Yep.
most new practitioners don't expect to get it done in 4 sessions.
Right.
I fall right into the unrealistic expectation category. And because I'm not an osteopath, and what you told me to do was just like, I don't even know where to start, I did what chiropractors do, and her pelvis was cattywampus, and you do it with muscle energy technique, and I put her on blocks and then used an activator. And not only was her pelvis cattywampus, her sacrum was cattywampus. And I'll know in 4 weeks when I see her again. But it's, yeah, you find it, you miss it the first 5 times, and then eventually, because the frequencies never don't work, once you get that, then you tend to find things sooner. And serious stuff like the aneurysm, the lymphoma, the ovarian cancer, the colon cancer, that's where actually the visceral section comes in handy. And I don't throw those warnings in the physical medicine section like I should, which is, I never ask patients, have you lost any weight lately? Patient comes in with low back pain and you have them bend forward, bend back, a side bend, you do that, and their pain doesn't change. The next question should be, is your pain worse at night? And the next question should actually be, have you lost any weight? Yeah, actually, I have. I'm so proud. I lost 15 pounds. How long did it take you to do that? I don't know. The last month, it's been great. I didn't even have to change my diet. And it turned out that patient had lymphoma. And her GP had her on Tylenol 3 for 2 months for this back pain.
So in that case, did you say go back to your GP and get a
The first time I told her to go back to her GP, I wrote her a note,
Yeah.
take this to your GP. And he said, oh no, it's just low back pain. You're 59 or 69 and you're going to have low back pain. And she came back to me and the pain was the same. It was not mechanical. And so I said, wait here just a minute. And on letterhead, I typed a note to him that said, dear doctor, the Mrs. has low back pain that does not appear to be mechanical. It is not made worse by any physical motion. She is 69. She has an intact uterus. She has both her ovaries. She has a family history of heart disease, and her pain is in the referred area for the colon. How did I put it? My medical legal situation would be better if I had appropriate imaging or assessment to rule out serious pathologies such as aortic aneurysm, colon cancer, ovarian cancer, uterine cancer, or any other serious pathology that could refer pain to the low back. And I copied the patient. I gave the patient a copy of the letter, and I told her to go to her doctor and take this letter to him.
Yeah.
4 weeks later, she came back and she said, I think you saved my life. I have lymphoma. Now, it wasn't on the things that I guessed at.
But that doesn't matter.
He found it. All he had to do was do blood work. But for him, it was a low back pain, and a female is just a throw off, and they don't know how to do physical exams the way the whole first part of the advance now is nobody does histories and physicals like you do because nobody has a tool that makes the information you get in a history and physical so important. So anyway.
And the exam importance is great, obviously, to rule out pathology or gives you a good starting point. But that's where you go back and you can retest. So sometimes when the pain's not drastically changing, at least structurally, you can see a lot is going on. And that to me gives me hope. Okay, I understand. And I think that is really important for the people who don't have a lot of pain. So these people will come in, for me especially, where it's more of a performance, right? I want to get faster, or this muscle starts to hurt at mile 7. It's not somebody who's very sick or in a lot of chronic pain.
Yeah.
So when they don't have a 7 out of 10 or a 6 out of 10, if they're coming in with a 2 or a 3, or they're just super irritated with the pain, your physical exam is going to give you much more of a measure if your treatment was a success, because at least then they can be like, hey, my arm used to stop at 90 degrees and now I can reach up high again. So that just tells you a lot more than just, oh, it's your labrum. No, it's the subscap. Look at you.
And it's the patient too that you do range of motion in the neck and their pain levels are 5 or 6. And they say, well, it hurts when I do that. And then you treat them and they say, well, it still hurts when I do that. And I said, let's measure the range.
Right.
You used to stop, it used to hurt, and you would stop at 50 degrees, and now you're at 70. And it should hurt at 70 because otherwise your head would fall off. Oh, so the numbers make a difference. It's like it's an angle finder. Kevin has made me promise to videotape the physical exam just so people know what does it look like when you use a pinwheel.
Yeah.
So we might borrow David Eakes this because I only have that kind of video stuff. Maybe borrow somebody and videotape a physical exam. That
The nice thing with the pinwheel too is you don't have to get so caught up in the millimeter. It will be icky on one side or dull on one side. A lot of it is just symmetry. So yes, it's nice to know dermatomes, myotones, nerve route, and that gives you a great guide, but you could just do left and right if you're so caught up and so flustered, because it will be very apparent that, yeah, it feels prickly, and then it's get that off me. Icky, gross, or are you doing it? I don't feel anything.
does this feel like that? No. Yeah.
Yeah, just a fantastic way to even just measure nerve pain.
And it's one of the things I love about FSM practitioners. One of the patient's complaints about everybody else they see, including sometimes even physical therapists, is that nobody does a physical exam. Nobody touches them. It's like my low back hurts. Oh, here, take this prescription. I'll see ya. And, or, okay, bend this way, bend that way. Here, do these exercises. I'll see you next week.
Yeah, I get it. People have a lot of different models. I think I was saying this not too long ago. It was a new shoulder client that came in, and I said, okay, do you have I always say bring a sports bra or a tank top or whatever. I said, is that a sports bra? Yes, it is. Okay, I need to see your shoulder. And she had just rolled up her t-shirt and did that. And I said, I need to see your shoulder blade. She's like, for what? And I said, to look at the way your shoulder's moving. So nobody's ever done that before. This person's been at it for a year and a half and nobody's looked at her shoulder blade. She's only had to roll up and have somebody examine the glenohumeral joint. And I'm a bit of a shoulder aficionado and nerd, and I was trying to explain scapulothoracic rhythm and scapulohumeral rhythm and how the two joints are synergistic. And she's, wow, you really love explaining this, don't you? And I said, I think it's important for somebody who's been like very committed to their rehab for so long to understand it.
Yeah. And because of the way you teach and because of the way the supine shoulder practicum, which used to be the prone shoulder until it really was impossible,
Right.
supine shoulder practicum has evolved. Our practitioners pay attention. This is not it. No, it's glued to the scapula.
Yes.
We work together.
Yeah.
And with you reinforcing it, especially in the rehab course and the sports course, it's, oh, that's how you fix a shoulder. Okay.
Right. It at least, I think, reinforces the tools, again, going back to that word of there's two joints to look at, and they both are equally important. They both have to work together. One cannot operate without the other. And it just makes you more thorough, comprehensive. And
Wow.
again, you're looking, what's the driver, right? The glenohumeral joint just doesn't stop moving from outer space. Is there a trauma? Was there a period of immobility? It started the glenohumeral joint, but then the scapula started sticking to the rib cage. And now maybe that's why like when imaging shows that, oh, there's no labral tear and no, the joint looks fine. Yeah, because the subscap is stuck.
Yeah. And then has anybody ever looked at your neck?
Yeah.
They did an x-ray. Oh, okay. And then has anybody ever done your knee reflexes? My shoulder hurts. Why would somebody do my knees? Okay. And
Yeah.
for FSM practitioners, at least I hope, it's a no-brainer. Like you can't assess the shoulder without finding out if the knee reflexes are hyperactive. How do those two things go together? Remind me. If the knee reflexes are hyperactive, it means there's something wrong in the neck. And if there's something wrong in the neck, then that's why the shoulder hurts. And it takes a while for you to connect those dots. It's like if there's a disc bulge in the neck, it slows descending inhibition and you get a hyperactive patellar reflex. And I've actually had 2 MDs in 2 different cores tell me straight up, nobody ever told us that in med school. So you get a hyperactive patellar reflex. That means there's something wrong in either the thoracic or the cervical spine, usually the cervical, because of how many accidents have you had, right? And then all of a sudden my shoulder doesn't work. There's no way that's how those things go together. Knee reflexes, neck. Then you work on the subscap. Why do you work on the subscap? Because the C5-6 disc is probably bulging, irritating the nerve, makes the subscap sticky, and that changes the scapulohumeral, did I say that right?
Yep.
Scapulohumeral rhythm.
Yep.
Because you can't do this and you can't do that, because the cerebellum is turning down the muscles that do that in order to protect this because of that and because of those reflexes. And it's just like our practitioners are the only ones that think that way anymore.
Right.
50 years ago, that's the way MDs thought.
Yeah.
That's the way, maybe not, but osteopaths think that way.
Mhm.
And it's, so I like our practitioners.
I love our practitioners, but I was going through some courses that I want to take for this year, and it dawned on me a lot of the courses that we have for continuing education or whatever, it's very like treatment based, right? If you have this is what you do. Not a lot of it is assessment based. This FSM training has evolved from.
Yeah.
And I think that's why it's getting longer and longer, because we get to the point of, okay, if you have this, you actually have to do these tests. And if you have that, you actually have to support it with X, Y, and Z. So it's not just treatment, it's diagnosis, supporting that stable state that we talk about, who to refer to, because you can't possibly do everything. It was funny, I went to get my eyes tested and my pupils dilated, and I was talking to my optometrist because she's doing a lot of vision therapy. We went down the vestibular wormhole together and we're talking about prism glasses. And she said she's never been more dumbfounded watching somebody who couldn't even walk down the hallway put prism glasses on, stand up straight, and walk out. Like instantly.
Yep. And for FSM practitioners, it's on the last day, and I finally videotaped it separately, so it's available separately. And every single advanced, for as long as I'm involved, John Reske will be part of the advanced because it's so important. So I have this patient she came in Monday with her husband because he had to do the talking. She's had 8 head injuries. She's had 3 COVID vaccines, COVID once, and she is in cognitive decline, but it's more than that. She was nonverbal. She could speak really slowly. She did not make complete sentences. And in my intake paperwork is the BIVSS. So that evaluates the effect of the vestibular system, whether it's in the brain or the ear, on function. And so I looked at her score, and it's 41 over 18. So you already know that has something to do with it. So I ran quiet the vestibular system on her while I ran concussion in Vegas, -94, just in case, and COVID in the capillaries, the cortex, and the vagus. She got up off the table and was speaking in complete sentences, speaking normally. And then I did the vestibular screen on her. There's no way to do it before I treated her because she was just not there. And sure enough, tuning fork lateralized to the left, was hyperacoustic. That's really loud on the right. And she had saccades to both directions, but when I went to the right, she just went, oh, that doesn't feel good. And it's important that our practitioners, like, literally are the only ones that find it anymore, that even look for it anymore. And then you have to find an optometrist that has already been trained in that. So the
Right.
prism glasses that's just awesome.
Yeah, my optometrist is unbelievable. She's very holistic, just a good, solid geek too, that we can like talk about things. Yeah, she was like, oh, that sounds really interesting. And she does a lot of vision therapy, which is very cool.
Is a good thing.
Did we have any questions before I go further on to
I'm
something.
looking for Q&A and I don't see anything. Oh, Leaf said, I know we don't treat cancer, but I use central pain protocol to ease a terminal friend off of hydromorphone. And that is correct. It's like once a patient is terminal, FSM is great for treating their pain. And you can reduce the dose of morphine that they need. Usually, when they go in the hospital, most hospitals make them stop using FSM, which increases their morphine, which makes them less communicative and they sleep a lot just before they die. But we've had so many case reports treating radiation burns, treating the nausea from chemotherapy, and the central pain, thalamic pain, that's a reasonable start, but also just treating inflammation in the organ and the organs around it that have cancer. So if a patient has mets to the prostatic cancer, likes to metastasize to bone. Bone mets are incredibly painful. There's a protocol in the advanced that I'm going to warn everybody now, I'm not going to get to, but you have the slides and they're searchable. So you use the bone mets protocol and it relieves the bone mets for 8 to 12 hours. So you run it twice a day and you can keep them comfortable at home and keep the dose of morphine and Librium at a minimum once they're in hospice. There's no reason they have to die in the hospital or go to a nursing home. As long as they're continent and you can get them to the bathroom, as long as they can still walk or use a chair side. Helping people die is it's an education, but it's a real blessing to be able to give them comfort at that particular time. Usually it's family members, but if you're a practitioner that is asked to make a house call or asked to program a custom care or to add a program to a custom care that mom or sister or daughter has to ease someone's terminal pain, there's
Yeah,
it's
that
just
is, it is a blessing. You said it at first, you're just like, oh, that's very heavy, and it definitely is, but it's more profound than helping the average everyday person that kind of goes back to their life. So that is a
and
very,
we know ahead of time none of us are getting out of this alive.
yeah,
We just hope to make it as comfortable and make the transition as easy on everybody as possible. The family, it's so much easier to let the patient family member transition if they're comfortable.
yeah,
If they're in unmanageable pain, it's just awful. And then you end up treating the family member for PTSD. But if you can help them, and if you're not afraid of it,
yeah,
it's if you get it, that
yeah,
it's, oh yeah, some people have back pain, some people are dying of prostatic cancer. It's our job to help. That's
right.
our job.
Yeah, and to just play with words, you said blessing, it's a privilege. Let into that person's stage of life and to be trusted to assist in that case. So I think that's wonderful, Leaf, what you're doing. Good for you. Was there any more distance treatment? Oh, and the person was off the meds completely.
Yeah.
Shout.
And I guess we can go there, although we don't usually go there. Leaf was treating the patient at a distance. And that is a concept that I have, and Leaf has it because of Harry. I have it because of George, who had it because of Harry. And it's not as strong, it's not as profound as when you treat on the body, but you have an electromagnetic field that is your body, but you have a magnetic field that goes out the front, around the planet, into the back on both sides. It's a toroid. It's this big circle. And that means if Leaf has a picture of you, the magnetic field is invisible. You can't see it. But the magnetic field that comes from your picture, now this is theoretical, but it seems to work. The magnetic field that you have is not visible in the emulsion on the photograph that shows the colors. That's a picture of you. But the magnetic field is still with you, with the picture. Harry and George and a bunch of our practitioners who got the word, you take the photograph and you put it on a piece of tinfoil or copper that conducts the current, and you hook the alligator clips to the tinfoil or the copper, red and green, and then black is kitty corner, just the same as you would on the person, and you put the person's picture on it. And then you run the same frequencies that the body would need, and you run it on the photograph. And George did that pretty much for a living. That's what he did all the time. And I've had him treat me. I've treated myself that way. After I worked 12 hours, ran current on myself 12 hours a day for 6 weeks, I couldn't stand to have microcurrent or sticky pads on me. But if my shoulders started to hurt, we'd hook my shoulder protocol up to my picture and run that. And it took 40 minutes for the pain to go down, but it worked. It's Leaf. I'm not even going to go there. So no, Harry used to use HVG, as Harry Van Gelder used to use a blood spot as a witness, or it was connected to the patient. And it's like, that is a step too far for everybody except people that knew Harry back in the day.
So interesting.
Yeah.
I have 2 books that I wanted to, somebody had asked me, I talked about one book a long time ago. For those of us who are very overwhelmed with Ehlers-Danlos patients, and it's a thing. There's a lot of them right now, and I don't know what is happening.
20% of every class.
There's a book, I talked about it before. It's called Mast Cell Activation Syndrome. So this is about mast cell. Amber Walker is a PT. The book reads like a novel and a textbook all in one. And then she also wrote this other book called The Trifecta Passport. So tools for mast cell activation syndrome, POTS, and Ehlers-Danlos syndrome. So these have been very great resources for myself, who I don't remember learning any of these, let alone how to recognize, support, treat. So I love those 2 books written by Amber Walker.
If she has contact information, like email the author, can you email her the Ehlers-Danlos webinar?
I should. She has a website here of originwellnesscolorado.com. So I will look.
Because there's FSM is the only thing I know about where the patient gets up off the table after 60 to 90 minutes with normal range of motion, normal heart rate, normal vagal function, and the POTS is gone. It doesn't hold, where it holds for a week, and the mast cell is still there, but then you just do leaky gut, treat the vagus every day.
Yeah.
And I don't know, 8 to 12 weeks, it's gone. And then the patient needs a custom care or needs to come and see you once a week, however they want to do it.
Right.
And nobody but our group, like Ehlers-Danlos, is in the core now. That's why the core is now 5 full days, and it actually should be 6, but we just can't go there. And it's Ehlers it's just not that hard. It's wonderful that somebody's written a book about it. But
Yeah, like you said, and it reads very like a novel and a textbook all in one, because a lot of it is very overwhelming. Going into mast cells and histamine, if you have trouble sleeping at night, you can start reading about the, the
yeah,
chemical breakdown of mast cells. But no, this is a very informative, good book that I refer to very often for those types of patients.
if you find things in that book, which I'm unlikely to read,
Yeah,
but if you find things in the book that would influence or change either our MCAS protocol, or I can't imagine it change anyway, the MCAS protocol especially, but POTS we know how to fix. You just turn the vagus on. Ehlers-Danlos is fairly straightforward. If it's combined with tethered cord, it's a little more complicated because you have to do the tethered cord first.
Yeah.
And then do the Ehlers-Danlos, and then do the tethered cord, and then do the Ehlers-Danlos again. By the way, I had a patient with low back pain, and he was stooped forward. And I remembered Eduardo's videos that he's been posting on Facebook. For anybody that hasn't signed up for the symposium, no, he's doing an advanced lecture on the dura. I did adhesions in the patient's dura, and this was the second or third treatment. You mean they did an epidural and okay. So I treated adhesions in the dura and his back pain went away.
Eduardo, I can't wait. I can't wait. I can't wait. I can't wait.
I'm so excited.
I'm like a little kid just waiting for like Christmas or my birthday. But it's 4 o'clock, and that's just gonna have to do for today.
Louise, look up Tethered, Tethered. It's a place where the spinal cord is adhered, well, spinal cord and dura are adhered usually at about T12 or L1. So they're stuck at the bottom, which puts pressure on the base of the skull and creates pain at about T12 L1 that nobody can fix. And then for us, it's easy because you treat scarring in the dura and scarring in the cord and have them bend and rotate. And I talked really fast, but it's only 4:01.
You did it. We did it.
But you can look it up.
We can look it up. And this is it until we see each other in person.
Yeah. And next Wednesday, there won't be any because I'm going to be in the middle of the core.
Yeah.
And then the Wednesday after that, we do it in person.
And we're going to be an hour later. So that gives me a chance to finish up the sports advance. So we
okay.
do it. Yeah.
4 o'clock.
4 o'clock Pacific Standard Time. I never remember if Arizona changes time or doesn't.
Wait.
Arizona does not change. Arizona has its own, it doesn't do
Daylight
savings time.
Right. And daylight savings time switches on
Soon.
the 9th. And so we're going to be doing the podcast on the 12th.
Yeah.
And that's after daylight savings time, which is not something Arizona participates in. So I'm actually not sure what time it's going to be in Arizona.
It will be at 4 o'clock Arizona time.
4 o'clock Arizona time.
Yeah.
Yes.
I think it's 3 o'clock Pacific time, but I'm not sure.
Yeah.
Okay. So just look for a 4 o'clock Arizona time, not this Wednesday, but next. Thanks, everybody.
Kevin will send out an email.
Kevin will do that.
He will. This is true.
All right, everybody. Thank you so much. I will
See you in 2 weeks. Have a good time. Do good things. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.